opportunity to the Serva team for providing us this grant where we are able to real-time work with our veterans in the dialysis unit assessing frailty. Now, we know that over 4.5 million US veterans are 75 and older. But are we aging in a healthy manner? So the goal is promoting healthier aging, which is extremely crucial. And VA being a large integrated health system, can we redirect our resources that are available within the VA, or can we develop interventions for those veterans that need them the most? That's really the background for our work that we are doing. Now, while age is considered a surrogate for health risk, other comorbidities, especially kidney disease, along with the age, creates a very high risk for adverse health events leading to frailty. So what is frailty? So it's a clinical syndrome which is manifested as decline in health and functional status, which results in an individual's vulnerability for developing dependence on others or death. So there are several proposed mechanisms for frailty in kidney disease, including inflammation, where we have all the reactive oxygen species, low antioxidant levels, endothelial dysfunction, and we have decreased clearance of the pro-inflammatory cytokines like interleukin-6 and TNF-alpha. There's sarcopenia in the patients with kidney disease, malnutrition with restriction in the diet, just accumulation of the uremic waste and metabolic acidosis, weight changes, several things that sometimes get overlooked, including the psychosocial factors, are very, very important contributors to frailty, as are some of the comorbidities, including the age that we talked about. So why do we want to look for frailty in dialysis population? Because what we see here, this is a meta-analysis from 7 studies which looked at prevalence of frailty in all the dialysis, either incident or prevalent dialysis population. And what we see is, if we compare to normal community dwelling population, the incidence or the prevalence of frailty is less than 10%. Compare that to the frailty burden in dialysis population. It ranges anywhere from 50 to 75%. So very high prevalence of frailty in dialysis population. We have aging veteran dialysis population. It is very important for us to look at frailty in our dialysis population. Now, there are different ways that we can assess frailty. We have chosen to go with frailty scoring, which was developed as part of the Cardiovascular Health Study Collaborative Research Group. This frailty phenotype has actually been validated in dialysis patients, and it's relatively easy to perform. It includes 5 physical characteristics of unintentional weight loss, more so recent in the last year, of more than 5% weight loss, weakness, which is measured through the grip strength, exhaustion, which is more self-reported, walking speed, where we make the patient walk 15 feet and look at this, the time it takes them to cover that distance, and physical activity, which is also self-reported. Now, there are set standard matrices based on which the patients may be scoring a point for any of the 5 criteria that are listed here. If they score a 0, that means they're doing really well and they are not frail. But if they score either 1 or 2 points on this, that means they're already pre-frail or intermediate frail. And if they score 3, 4, or 5 points, then those patients are frail. Now, again, why is frailty important when we are studying it using this phenotype? Because if the patients do go on to develop frailty, for patients who are not yet on dialysis, studies have shown that there's increased risk of death. And as the stage of chronic kidney disease increases, the incident frailty increases. For our dialysis patients, it's been associated with increased death, hospitalization, falls, loss of vascular access, which is their lifeline, poor quality of life, and longer dialysis recovery time. all these factors tie in very, very important to a patient's care. Now, even if the patient was to get listed for a kidney transplant, there's a higher chance that a frail patient will die while on the wait list. A frail patient who's still on dialysis will have a lower chance of getting listed for a transplant. And even if this patient gets listed for a transplant, they will have lower chance of getting a transplant. If they do end up getting a transplant, the post-transplant outcomes are also poor in these patients. So Heinz has recently become a transplant center also. So we are collaborating with a transplant center as part of the study, as we will show you in our team a little bit later. So while we are studying frailty, is there anything that can be done to reduce frailty in patients with kidney disease? So that is really our goal, to work with our veterans while we identify the frailty, we do the screening, then we want to work with them with the interventions to reduce frailty. So as Holly pointed out earlier, our study, the feasibility of assessing frailty, so doing the frailty screening and designing a veteran-centric physical activity intervention, that's our other aim for the study. I'll very briefly go over what we have done so far as part of the study. We enrolled 82 veterans who were in the dialysis unit. We approached them. And we realized about a third of the veterans, we could not even assess the frailty in them because some expired, some were paraplegic or bedbound, some transferred to the other units, relocated or got transplanted or switched to peritoneal dialysis. So among the 58 veterans that were there, 13 of these veterans, they refused to complete the frailty assessment. So we assessed frailty in 45 veterans. All of these, what we have shown in this enrollment diagram, each one of the aspects is a very, very important aspect, including the one third of the patients that we could not do the assessment on, and even this subset that did not complete the frailty, and we have the reasons listed for them here. What we found was, as part of the screening, that very small number of our patients amongst the 45 that we did the study for, only 5 of them had a score of 0, meaning they were non-frail. There was a significant number that was intermediate frail, and then another significant number that was frail. Now, when we looked at the individual markers, and this is very interesting for us, between the 5 phenotypes that we look at, so looking at each of the individual phenotypes, what we realized, and which is something little bit of a unique finding of our study, we are keeping in mind that our N sample size may be smaller. Most studies talk about slow walk as the key feature in these patients, in dialysis patients. What we found was the weakness or the hand grip. And that brings even several more questions to mind for our patients. And some of the other phenotypes with their percents are listed here. So again, if we look at the frequency of individual frailty indicators, what we see here, low grip strength among the frail patients, we found that in 100% of our patients, combined pre-frail and frail, 90% of our patients had low grip strength, almost 60% had slow walking speed. I won't take you guys into more details of what we saw, patient characteristics, but in general, this is where we look at the patients who did not complete or refuse to do the frailty assessment, and those who completed. There were some interesting, at least trends that we were looking at, that the patients who refused had more peripheral vascular disease burden, and that may be one of the reasons that they didn't want to participate in the study. And another important thing that we noticed was that all of the 13 patients who refused, all of them had been declined transplant listing, which is, which is something very important for us to keep in mind, that just because the patient would not be a candidate for transplant, there's still so much we can do by improving frailty and their quality of life, that it's a very important aspect for us to look at. So just to sum it up, we saw that frailty screening was feasible among our dialysis veteran population using the FREED frailty score. We had 52% of our patients complete the screening. 88% of our patients were identified as pre-frail or frail, low grip strength being the predominant phenotype, and slow walking speed was the next most common phenotype, and higher rates of non-completion were associated with vascular disease, low albumin, which is an acute phase reactant and has been shown in other studies, similar findings in other studies also, and patients that were declined listing for transplant. So, we see that there's a high proportion of dialysis patients that were identified as frail or pre-frail. So frailty may be going under-recognized in our aging dialysis population. So that means there's a significant number of these patients that may benefit from targeted frailty reduction interventions, and that's the direction that our project is looking forward to taking. Our goals, which may be a little ambitious, are to have a dedicated frailty assessment clinic. We do want to call it frailty assessment and intervention, or maybe a FIT clinic, which will provide routine frailty assessment to the veterans. If we are able to establish a basic infrastructure that will serve as a prototype for larger clinical program aiming to optimize assessment and management of frailty among veterans with kidney disease. Once we have this prototype or pilot established at Hines, this project can easily be adapted at other VAs nationwide. And our hope is that for patients that may be getting declined listing or maybe deferred listing for transplant, over time will be able to reduce their frailty and get listed and get the transplants and improve patient outcomes. That way, those that have really progressed to a point that the transplant is not an option, we still want to be able to provide a better quality of life to our patients. So with that, I would just like to acknowledge our multidisciplinary exciting team that we have put together as part of this project. And without whose help, this project would not have been where we are with it, finding such interesting data. We are collaborating with Dr. Megan Sheets from University of Chicago. She is a pioneer in this field of frailty and in geriatric population, and has worked with dialysis and transplant patients. Talar Marcosian, she is a research scientist. She's been tremendous and phenomenal. So has been Salva. We are working on, so we have already, we do have a publication as part of our project in nephrology, dialysis, and transplantation. And we are working on a poster which got accepted in Academy Health dissemination and information, so D&I, which is coming up in December in Washington, D.C. So we are very excitedly looking forward to that. And Talar and Salva are helping with that, and the rest of the team too. Christine Jelnik, without whom we would not be able to do these studies. And Dr. Stroop's name is not new to any of you guys here. He's been phenomenal with his support, with his team support. Dr. Lopez, he's the kidney transplant surgeon and the director for the transplant program at Hines. He's been instrumental in his support of the transplant department. I don't have my picture and Dr. Samra's picture here. We are the main investigators. Don Irwin, our project coordinator, a couple of new members on our team, Gabrielle, who has helped with the project, and Cameron, who recently joined with his exercise physiology background. Dr. Shah is a transplant nephrologist, and a renal fellow, Dr. Paletti, has also helped with the project in some of the aspects. So very appreciative again of the SERVA for providing the opportunity in bringing this team together and hoping that we can make a difference in the lives of our veterans on dialysis and kidney disease. Thank you.